Hi everybody, so I'm Hugh, I'm a PGR with HSC. I also work at the Norfolk and Norwich Hospital in the Acute Medical Unit as an assistant practitioner. Today I'm going to be talking to you about the findings from a qualitative systematic review about understanding the perspectives of emergency nurses on triage assessment of acuity at initial adult patient presentation. So every day, thousands of patients attend emergency departments across the country and have their acuity assessed when they arrive. Acuity is a measure of how sick the patient is and how rapidly they need treatment. Triage nurses assess acuity to calculate acuity scores, placing the patient into a time frame to be seen and treated. You can see here the time frames from the Australasian triage scale, ranging from red, needs to be seen immediately, down to white, seen within 120 minutes. Triage tools are used to direct their assessments and calculate a score. On the left, you can see the emergency severity index. On the right, the Manchester triage scale, both triage tools commonly used in the UK. However, significant differences can occur between triage tools and practice, with nurses making decisions that go against the tool's advice. An exploration of the perspectives of nurses will help us understand how they can make these complicated acuity assessments and the reasons they deviate from the tools. While several literature reviews in the field exist, no systematic review has attempted to explore all factors together. Therefore, we've conducted this systematic review. So how did we conduct it? First of all, we developed the research question. We used SPICE, with setting relating to emergency departments. Population was registered nurses, ranging from newly qualified to very senior. Intervention was the triage assessment of acuity. We had no comparison. And our evaluation was understanding the perspectives of making triage decisions. We used this to form our research question, understanding the perspectives of emergency nurses on triage assessment of acuity at an initial adult patient presentation. A review team was recruited via advertisements placed using posters in a doctor's office on the acute medical unit. 6 review members initially joined, with a 7th joining during the full text assessments. The split between nursing staff and medical staff was 50-50. Search strategy was kept wide. 3 databases were searched: Medline, CNAL, and Academic Search Complete, with searches taking place between March and May. Population for the search was nurses and related terms. The setting was emergency department, and again, related terms. And the intervention was triage or acuity, severity of illness, all terms used in the literature. Searches weren't restricted by geography or by date to ensure full capture. However, our screening criteria were much narrower in order to focus down the papers to what we needed. An inclusion criteria was nurses working in emergency departments, patients which had to be over 16. If there was a mix, it had to be 80% over 16. The triage had to be face-to-face in order to eliminate papers that focused on telephone triage. The focus of the paper had to be on the process of the assessment of acuity. Papers had to be either qualitative or mixed methods, and the paper had to be final research. For the exclusion criteria, we excluded papers that were focused on specific presentations of illnesses, because these will quite often have their own identifying methods that don't generalise. If the patient's main presentation was maternity or mental health, these were also excluded. If there was, again, mixed in, that was acceptable, but where they focused on these had their own processes and own pathways. Papers that used simulations of triage were excluded. We wanted actual real-life information on how the nurses do it. And papers published in languages other than English were excluded. For the critical appraisal, data was extracted using a standardized form. We captured bibliographic information, study design, participants, and main findings. The methodology was appraised using the CASP qualitative tool, as you can see here. Data analysis, we did inductive line-by-line coding of the papers. Coding papers are undertaken independently by 2 researchers, with codes compared and then merged together. They were then compiled into a centralized list and organized into descriptive themes. Themes were created for group discussion using nominal group theory in order to achieve coherence. Descriptive themes were compared to the research question produce analytic themes. Grade circle was then used to assess the confidence in the review's findings. Grade circle is a method of assessing confidence. It's made up of 4 components: methodological limitations, assessing how well the studies have been conducted, if their methodology is good; coherence, assessing how well the data from the studies matches the review findings; the adequacy components, is there sufficient data and is it rich enough to support the findings; and relevance, was the paper's population, location, aims, methods all appropriate to what our research question was asking. Each of these is assessed with and given a level of concern. That level of concern is used to create a level of confidence in the research findings. So what did we actually find? Well, our initial searches raised a little over 12,000 papers. When we removed duplicate records, we found 7,636 papers to screen. Title and abstract screenings removed 7,519 papers. The agreement was 99.15% with a Cohen's kappa of 0.8. We saw 117 records for retrieval, could not retrieve 12. 10 of these 12 papers were dated from 1975 to 1980. Reports were assessed for eligibility, and we excluded based on the criteria seen here. At the same time, we searched the grey literature. We searched websites, organisations, we searched citations contained in our included papers, and we hand-searched journals. We saw 13 records and couldn't retrieve 1. We assessed 12 for eligibility and excluded 10 of those records. The full text agreement was 90.75% with a Cohen's kappa of 0.77. We finally included 28 studies in the review, all of them qualitative. For data extraction, we filled in our tables, and examining the dates published, we had papers ranging from 2002 all the way up to 2021, with the majority taking place after 2014. Locations of the study, we found a broad coverage from the globe. We had a couple from the UK, we had quite a few from the Scandinavian countries, a few from Iran and the Asias, a few from Australia and South America, and a lot from North America. The quality of the included studies was, on the most part, good. We had concerns around recruitment strategy in a few studies. In some cases, they hadn't listed how they'd approach patients, nurses. In some cases, we found that they hadn't described what their inclusion and exclusion criteria was. We had serious concerns relating to reflexivity between the researcher and the participant. Many papers did not describe this or did not go into much detail. In terms of ethical issues, there was some lack of describing of informed consent and some lack of describing of ethical committee values. Data analysis, there was a few minor points missing here and there. Some didn't go into full depth on their analysis, nothing too serious. And in terms of value of the research, again, it was bits missing. They hadn't described future research. They hadn't described implications for policy or practice. You can see here a mind map made up of our codes. These are all the codes used and how often they were used. We then gathered those codes and transformed them into themes. These themes we then gathered into domains. That took forever to animate. And you can see here 5 domains we established. We took those domains and took the themes contained within and produced 15 analytic themes. Our first analytic theme was that nurses gather information through visual, vital, and verbal assessments, with the most weight given to visual and the least to verbal. Our confidence in this review finding was high. We found that visual assessments were highly favoured by nurses, and it's a highly intuitive process. Vital assessments were considered objective, but were quite often overruled by the visual assessment. They were making subjective decisions and not backing them up with objective data. Verbal stories were seen as highly subjective and were assessed for credibility. However, certain red flags in their verbal assessment, such as chest pain or tightness, could override the other aspects, promoting verbal assessment to the highest. You can see on the right, Rostow et al., one of our studies, talked very highly about this factor. Our second finding was that nurses holistically gathered information about the patient to make a full assessment of acuity. This was seen as a focus on the individual, not a generalization of the patient presentation. It was informed by the visual, vital, and verbal assessment. The presenting complaint and symptoms were linked with psychosocial aspects to assess the patient from all perspectives. And there were feelings that holistic assessments were not performed as often as they should be. This finding was only rated as moderate due to the fact that the adequacy was low. We found papers that talked about it, but not as much rich data as we would have liked. Our third finding was that nurses interpret the gathered information through clinical reasoning and intuition, moving back and forth between the two. Our confidence in this finding was high. Nurses utilised both of these factors to make their assessments. Clinical reasoning involves logical assessment, pattern recognition, and critical analysis. But intuition is a rapid decision made without that analysis. Intuition is highly favoured by the experienced nurses. They talked quite often about using their intuition and how important it was to them. However, they also described using both, moving from one to the other. They'll make an intuitive decision and then critically analyse it. They'll critically analyse it and then make an intuitive decision from that. Our fourth finding was that the nurse's professional knowledge and experience provides a basis through which the gathered information is interpreted. However, it's important to note that with this finding, we only rated our coherence as moderate. The match between the data and the findings did not quite meet. So we reassessed the data and assessed the findings and modified it to the nurse's professional knowledge and experience inform the interpretation process. This raised the coherence to minor, allowing us to give us a high rating. We found that nurses put high importance on experience and knowledge. The differentiation between less experienced and more experienced nurses was explicit in the text. Nurses often talked about how less experienced nurses would do one thing, higher experienced nurses would do another. These two factors were linked, but were not necessarily directly connected. You could have a high level of professional knowledge but a low level of experience, and vice versa. However, a lack of either was perceived to result in poor accuracy and missed cues. Our fifth finding was that the nurse's professional characteristics, beliefs, and biases can impact the interpretation process. Again, we had issues with coherence, this time raising serious concerns. So what we did was we split it. We took out the bit about the professional characteristics and turned that into its own findings, which I'll discuss later on. Therefore, we changed our fifth finding to the nurse's beliefs and biases can impact the interpretation process. However, by splitting our data, we changed the adequacy of the information from minor to moderate concerns. Therefore, we rated this one overall with moderate concerns. Nurses had a perception of the need to treat everyone equally. However, they also described cultural beliefs around the process of triage. They attached meanings to locations, meanings to decisions. They were cultural icons established. There were also biases identified relating to race, socioeconomic status, body sizes, and age, all of which impacted their assessments. They were perceived to negatively have impacts, resulting in mistriage. Our sixth finding was that acuity decisions are modified through the nurse's perceptions of risk. One of the quotes that I've taken out from 2014 that I think very well describes this is that the goal of triage is to prevent death. Triage was seen as a process of risk management. The nurses were constantly assessing the risks of their decisions, the risks of the environment. However, when they assessed these risks, they were adjusting the acuity scores, but they were also adjusting them for the potential risks, the risks that weren't necessarily there, but could be. They also felt a need to sometimes take risks in the acuity decision-making assessment in order to accurately and assess patients to ensure flow. Our seventh finding was that less experienced nurses tend to rely more on triage tools, whilst more experienced nurses favour utilising their knowledge and their intuition. Again, the adequacy for this one was rated as moderate concerns. We had 10 papers supporting this, with only 5 showing rich data. We found that less experienced nurses tend to rely on triage tools as a basis for making their decisions. They didn't have the experience necessary to work independently, therefore they attached to the tools and utilise their decisions. More experienced nurses would favour knowledge, experience and intuition. They'd make decisions separate from the tools. However, experienced nurses, when uncertain, would return to the tools and utilise them as guidelines, showing worth to the tools. However, our eighth finding was that triage tools are perceived as too generalised to be useful for assessing each individual patient's circumstances. For this, we found a moderate coherence. This was due to the fact that of our 11 studies, 7 had findings that supported it, 5 had findings that argued it. However, of those 5 studies, 3 both supported and had findings against, and 2 of them were conducted in places that had only recently introduced the triage tools, suggesting the nurses weren't overly familiar with them. The triage tools were seen as subjective. No, triage was seen as subjective and individual to the patient. The triage tools were seen as too generalised, not able to reflect this individuality. They couldn't identify the problems, the nuances that come with patient assessment. However, as I have noted, several studies did highlight the importance of triage tools in providing guidelines, in risk management, in providing legality. Our 9th finding was that nurses not only consider the acuity of the patient they are assessing, but consider that patient's acuity against the situational circumstances in the emergency department. For this one, adequacy was rated as serious concerns. We only had 7 papers supporting it. However, all of those 7, they all highly supported it, with rich data in 4. We found that decisions were not made solely about the patient's acuity, but instead they assessed factors about the wider department. They'd look at workloads, they'd assess how busy they were, how staff, how flow was. They looked at how sick other patients were and compared it to that patient's acuity in order to fit them in to a wider acuity scale outside of the triage categories and score. This leads to our 10th finding, that workload, staffing, resources and flow, all environmental influences, have perceived significant negative impacts on nurses' ability to accurately triage patients. They were highlighted by nurses as being very important to the process despite not actually impacting the patient's own acuity. They were seen to result in reduced accuracy and increased stress for staff. Flow was highly discussed in depth in several studies. Roscoe 2016 and Wolf 2018 both focused on the impact of flow on the acuity assessment process. Our 11th finding is that nurses attempt to moderate the impact of these factors through their decision-making processes, utilising timekeeping, manipulation and mistriage of triage tools, and gatekeeping. Nurses aren't just impacted by the external factors, but react to them. They use their assessments in order to try and mitigate their effects, creating a feedback cycle. They would speed up their triage processes, working quicker, cutting out parts of the assessment, quite often the verbal, as we said earlier, they felt they were quite subjective. They described manipulating triage tools to produce outcomes that would reduce the effect of these external pressures. They would mistriage patients, giving them triage scores that they knew were wrong, in order to send them to areas that they felt were more suitable or more able to cope with their workloads. They would gatekeep patients to prevent them from coming into the department when they considered them unsuitable or when they considered the workload high. Our 12th finding was that outside agencies, management and policies were perceived to interfere with the triage process. Nurses all talked highly about how they felt they could impact the triage process. Paramedic and nurse interactions were specifically highlighted as a source of tension. Nurses felt that paramedics would manipulate their stories and the assessments of the patients, and talked about how they felt, the nurses felt they should be doing their own assessments as opposed to just taking what the paramedics said. Managers and policies were perceived to be too focused on targets and patient satisfaction, but nurses would favour what's in the patient's best interests as opposed to what the managers and the targets needed. Again, the adequacy for this finding was rated as moderate, resulting in an overall moderate confidence. Our 13th finding is that nurses perceive conflicts with patients over the process of acuity assignation, with patient satisfaction seen as less important than acuity assessment. Nurses quite often describe conflict with patients, conflicts caused by long waiting times or what disagreements over the acuity scores, with patients feeling that they were sicker than they were the score they were assigned. However, it's important to note that nurses would favour an accurate acuity score over patient satisfaction. Whilst keeping patients satisfied was important to them, they would ensure that the sickness took place over satisfaction. 14th finding was that the wider nursing and medical team was seen to both support and hamper the process of assessing acuity. Team dynamics were very important to nurses. Nurses would consult other nurses when unsure about the triage decisions. They described a need for support from their colleagues about the decision-making process. However, they also described a need to be able to criticise their colleagues' processes, suggesting some hypocrisy. The nurses would assess the workloads of their colleagues and their ability to handle the patients they sent to them, perhaps diverting to other areas when they felt they couldn't. Perceptions were noted of the medical team not understanding the acuity assessment process, resulting in conflicts between nurses and doctors over how sick the patient was. Training in triage is seen as necessary, but severely lacking. Many nurses talked about how important training was to them, and it was linked to several other factors, including triage tools, reasoning, and knowledge and experience. However, there are strong perceptions from every paper that talked about training that the training given was not good enough, whether for new nurses first coming into triage or for experienced triage nurses in terms of refreshers and documents and policies. Our 16th finding, taken from our earlier one when we split it, was that nurses' professional characteristics support their ability to make triage decisions. Nurses feel a sense of responsibility towards making accurate decisions. They describe a need for autonomy in their role so that they can be free to make the decisions they need to make. They describe courage, adaptability, and emotional stability as key traits for a triage nurse to have. And they identified a sense of status and satisfaction from the job role. So our overall confidence was mostly high in our findings. We had 5 findings that we rated with moderate confidence. 4 of these were due to adequacy and 1 due to coherence. We had 1 finding rated with low confidence, second to adequacy of data. From our findings, and you may have noticed on the right side of the slide, I had tiny little diagrams, we can create a thematic map suggesting connections between all the various factors to establish how the nurses assess acuity. It's important to note that this is not a model and has not been tested as a model. This merely lays out the nurses' perceptions described in our findings. We can also map our thematic map to the domains that we established back in our themes, which shows us the areas that nurses work in when making decisions about acuity. So we've laid out the findings, but how do we actually apply it in practice? Well, our implications for policy is that they need to introduce sufficient training. This is a highly recommended finding. We need to ensure awareness of the effects of the external influences, of those workloads, of those staffing, of the flow and of the resources, and mitigate where possible, although understandably in our current environment that can be difficult. And we need to encourage multidisciplinary cooperation. We need to make the nurses and the doctors play nice. The implications for practice, the nurses themselves, are that they need to back up subjective assumptions with objective data. If they make a visual assessment, they need to check it and confirm it with the vitals. They need to ensure that a holistic assessment is completed. They need to assess the patient from all angles: visual, vital, verbal, psychosocial, symptoms, presenting complaint, to combine it into their assessment. They need to negate their beliefs and biases where possible. And they need to ensure that the patient's acuity is prioritised during the assessment. They need to focus on what that acuity score is, not how they can use the acuity score to mitigate other external risks in the department, not what the potential risks to the patient are, but what the actual acuity score is to ensure it is accurate and the patient gets seen in an appropriate time frame. So where do we go from here? Well, we can investigate the areas that had low adequacy in our grade circle to confirm or refute our findings. We can develop and test the thematic map further to work towards developing a model. And we can utilise our findings for direction themselves. I talked about how training was considered insufficient, but exploring how we can train nurses to triage better and what information about this lies out there is a potential direction for future exploration. My eternal thanks go to my review team for all their extremely helpful work, and my gratitude to my supervisors as well for their guidance and their fantastic support. Thank you.
Thanks very much, Hugh. Does anyone in the room have any questions for Hugh? While you're thinking, I will jump in with one, if that's okay.
Of course.
Why did you choose only qualitative to look at?
Excellent question. We chose qualitative because we were interested in the perspectives of nurses. The nurses are the people on the floor who are actually making these decisions. Whilst looking at from a quantitative method of what the best way to do it is would have informed perhaps future direction better. Understanding how the nurses actually make these decisions allow us to make changes that are acceptable and work with the nurses.
Okay, I just wasn't sure if perhaps there was work where they sort of quantitatively studied how useful the nurses felt the tools were, things like that.
There is some work, and I have looked at it, it tends to agree roughly with the findings.
Oh, well, that's good to know. Do we have any questions from online?
Yeah, I do would like to ask a question.
Yeah. Yeah, would you like to ask a question, Joe?
Thank you, Hugh. Can you hear me? Okay, in the room? Brilliant. Thanks for a really interesting, well done talk and really interesting piece of work you've done.
Thank you.
There are a lot of complexities in this area, aren't there? A huge amount.
Yes, very much.
One question I had was about the mistriage and the issue about beliefs and biases. And how do you distinguish between a belief or a bias and, on the other hand, experience of, the nurse's clinical experience in their role? And does this relate to mistriage? And could you give an example of how that might work in practice?
Yeah, so mistriage tends to be working around a manipulation of the tools. So it will be deliberately choosing a wrong score, whereas the beliefs and biases were more, they weren't explicit by the nurses. They were identified as happening, but the nurses wouldn't say, I would triage someone differently because of their race, socio-economic factors. I mean, thankfully, we hope that they would never do that. Rather, it was identified as influencing their decisions. They would make comments like, I think there was one from Wolf, 2010, who identified that nurses described patients of a certain ethnic culture having a culturally mediated pain response. They were more demonstrative when they were in pain, was the nurses' words, suggesting that the nurses felt when they assessed their pain, they would reduce the score a bit in order to mitigate these effects. This is a perceived bias. There was no evidence base behind it.
I see. Thank you. Thanks for explaining that. Yeah, I was wondering whether the mistriage related to kind of things they know, or like I think you mentioned sending a patient to a different department if they knew the ideal department was overloaded.
Yeah. So they would mistriage deliberately. They would also mistriage accidentally when their assessments are wrong, which can be caused by beliefs and biases, by not fully holistically exploring the data, many different factors. I think in the actual presentation, I only referred to mistriage in terms of deliberate mistriage.
Okay, thanks. I think there's somebody. Is that just me with my hand up? Yeah. Okay.
Yeah, I just wanted to say that was an excellent presentation, very comprehensive. There's just two questions that I wanted to ask you, and one was around your background, and I was really intrigued by the point around nurses making decisions that go against the tools advice, and I just really wanted to get a little bit more understanding around what impact that has, and really kind of that substantiation of the need for this study.
So those factors were kind of expanded upon in our findings. They would make decisions that go against advice for both deliberately, so in order to mitigate those external factors I talked about, flow and such. They'd make decisions when they disagreed with what the results of the tool was, so they might feel that the tool was resulting in too high or too low an acuity score and didn't reflect the actual patient's presentation. They might also inadvertently go against them when, as I said, they haven't properly performed the assessment.
So it didn't necessarily impact on patient outcomes?
It could potentially. So by misassigning a triage score, it means they get assigned to the wrong triage category.
Yeah.
This means that the patient doesn't get seen in the time frame they need to be seen in. They'll either be seen too quickly, which means resources are being misapplied. You've got doctors going to see that patient when they could be seeing patients who are actually that sick, or they could be seen too slowly. They're not being seen too quick enough. Accurate triage has, or inaccurate triage to be accurate, has links to longer delays in the hospital. So patients end up staying too long, whether in the emergency department or because they get admitted because they haven't had the treatment they need. It's got links to patient satisfaction. Patients are waiting too long for treatment. They're not very happy. And it has links to mortality. Patients who are inaccurately triaged shows an increased risk of death.
Lovely. And the next question was, I was really interested around the whole area around holistic assessment, because there's lots of evidence to support that, within that environment of care, that there's a lot of focus on the presenting problem. So you've highlighted, and I thought that was great, the visual, the vital and the verbal assessments, but there's not a lot of emphasis on the verbal assessment. Just tell us a little bit more about that.
So the verbal assessment would be things like the patient's history. It will be things like going up to them going, how are you feeling? Which admittedly as a practitioner is something I always do with my patients, because I personally think it gives you a good perspective of the patient. It could be related to the duration of symptoms. It could be related to the symptoms themselves, although they'll also be assessed visually and through the vital signs. The presenting complaint, as you mentioned, will be described by the patient. Part of the nurse's holistic assessment and part of their clinical reasoning, which I didn't go into in this too much, is that nurses quite often generate and hypothesize a diagnosis. It's not necessarily a medical diagnosis, so it's not the patient has got pneumonia, say. It will be more a sort of generalized thing to help the nurse organize their thoughts and group them. It will be the patient has breathing problems related to an infection. If they've got chest pain, it might be it's cardiac, it might be it's muscular. They'll sort of group them into that, and that's kind of part of the overall holistic assessment, which is then filtered through the clinical reasoning.
But I just see, because you were saying that there's a high level of holistic assessment, but if you're missing out that kind of the patient's narrative, doesn't necessarily equate to that holistic assessment. But that's good that you put that in your recommendations, which is really important. Thank you.
Anything on the lines?
Alice.
Oh, Alice.
Hi, can you hear me?
You're a little quiet. What I can do?
I was just wondering from a UK perspective and the RChem's position on navigation and streaming as opposed to triage, and the idea that they're trying to front load a lot of streaming and navigation positions with clinicians now rather than nurses. I just wondered if that was likely to have any effect on your findings.
To be honest, no, it's important and it works with my findings. They're trying to front load with clinicians. However, quite most of the hospitals in the UK, as far as I'm aware, are still actually using nurses at the triage desk for the assessment process. Clinician assessment over nurse assessment tends to be stronger. It also tends not to happen as much due to costs, staffing, various factors like that. In terms of working via navigation, that's an additional factor. There's a research study going on at the minute in Germany called the Triage study, which is very much looking at navigation and talks about triage. But in order to be able to properly navigate into the areas, you still need to be able to make business acuity assessment to know how sick they are, to know if they're suitable for those areas, would be my answer.
Yeah, no, I just wondered if clinician-led initial assessment was to take the forefront, then perhaps you'd be in a position where nurses were able to undertake more holistic assessments because they're not having to do that type 1 versus type 2 thinking. That was...
Yes, and that would benefit. There's also the question though around sort of duration of triage, whether the nurses then start to gather too much information and start to almost muddy up their assessment process. But it's sort of benefits of one, problems of another situation.
Yeah, no, really interesting. Thank you.
Thank you. No.
Thank you for the presentation. I want to ask you about the biases. One of the biases is age. Actually, I thought it is one of the criteria because, like, if we actually decide if the ages, I mean, the older people are different than the younger people. So how do you distinguish between the assessment criteria to bias around age?
Yeah. So this was age.
Can you repeat the question?
Yes. So the question was about distinguishing about age related to bias and distinguishing sort of between older and younger people and like that. Am I? Yeah. So in this case, it was a stigma attached to the age of the patients. Older patients were generally assessed as more frail based on the fact that they were older, not on their actual physical presentation. Various factors like that. They were seen as more likely to be sick. It was seen as people of an older generation are less likely to complain about pain. It was all factors related to age around that, sort of negative biases that with no actual attachment to objective data. Is that?
Yeah.
Okay, so we'll just have another round of applause for Hugh and his brilliant presentation.
Yep.
And as I said at the beginning, if anybody does want to present at one of these seminars, just drop me an email, or if you'd like to be involved